very good afternoon to all of you. Wishing all of you a happy Bihu, happy Posh Sankranti, happy Harvest Festival, whatever part of India you are. And we have gathered here today, and I welcome you very warmly for this welcome. And we are truly grateful that you have joined for such an important discussion today. And what we intend to speak on today is a very challenging disease called Pompe's disease. Now, Pompe's disease is a rare genetic condition which deeply impacts the lives of patients and their families. Living with Pompe's disease can be challenging, affecting the muscle strength, the mobility, and even breathing. Though greater awareness, timely diagnosis, and right now advancing treatments can work to improve advances and uh, the quality of life, and it can improve the outcomes. But even right now, diagnosis is still a challenge, especially if we are talking about the very early onset Pompe's disease. We are very honored today to have a very distinguished faculty who have huge experience in these fields, and they are highly respected experts in their fields whose knowledge, experience, and dedication would actually help us to understand this disease more, and hence may add some meaningful points to the clinical diagnosis, to the management, and how we look at Pompe's disease today. Thank you once again for being here. And without much ado, I would like to introduce our very first esteemed speaker, Dr. Ratna Puri ma'am. And she will be speaking on gene to phenotype, which is, again, as I said, because of the spectrum, it's very important. It's very important to understand this. So we all know Dr. Ratna Puri ma'am, but just for this official sake, to introduce her, she's a professor in genetics and chairperson Institute of Medical Genetics and Genomics, Ganga Hospital, New Delhi. And we all know her. She has memberships with Undiagnosed Disease Network of NIH USA, Lancet Commission on Rare Disease Panel of Experts of WHO Collective Global Network for Rare Disease, RDI, member of National Consortium for Research and Development for Therapeutics for Rare Diseases in India. She's a member research committee in the Sir Gangaram Hospital, New Delhi, member of Technical Expert Committee on Human Genetics, Genome Engineering and Nanotechnology Application in Healthcare, DBT, India. She has received a lot of awards, and she has always been very kind to impart her knowledge to all of us. Welcome, ma'am. And
Thank you
if
so
you could
much,
please highlight on the topic.
Thank you very much for a very kind introduction. And I think we all know today that today is, or this month is, the Pompe Awareness Month. And today is the International Pompe Day. So at the outset, I would like to thank ORDI and Prasanna, whom I have known, I think, much more than 20 years now, and greatly appreciate the awareness and the changes that he's brought about in the field of lysosomal storage disorders in our country. And so I was asked to speak on from gene to phenotype, which is really just an introduction to Pompe disease. And I'm going to start with a couple of cases because I think that's what really teaches us. Each case teaches us. And so, as you can see here, that this is a consanguineous family. The first child died without a diagnosis. And this young boy came at about 8 months of age because of developmental delay, which was predominantly motor. He was very alert, smiling, but he had rapid breathing and interrupted feeding and limited movements, as you can see, of the limbs. And on examination, there was some failure to thrive. There was hypotonia, the reflexes were not elicited. There was a systolic murmur along the sternal border. There was hepatomegaly. And if we carefully examine him, there was a tongue which was very prominent, which you could appreciate even in this. And the calf muscles were slightly prominent compared to the rest of the buck. And so his investigations were a slightly elevated CK An ECG, because there was a murmur, so an ECG and an echo had been done, which showed features of left ventricular hypertrophy, a prolonged PR interval, a wide QRS complex. And on the echocardiography, there was a dilated severe left ventricle with concentric left ventricular hypertrophy and outflow tract obstruction with a very poor ejection volume. Now, this is a prototype of infantile onset Pompe disease, but we would have differentials at this time with hypotonia, which is not an uncommon phenotype in the neonatal and first year of life. And so we always have to think in this broad term of, is it spinal muscular atrophy? What are the shared phenotypes and what differentiates it from what your child has? Hypothyroidism, in the absence of universal newborn screening in India, I think I would bring this even above spinal muscular atrophy. And then are the not so common phenotypes of myocarditis, mitochondrial disorders, the glycogen storage disorders, including Pompe, congenital muscular dystrophies. And so you have it here, and I'm not going to go into the details on the table, but this is how we have to think at the bedside, that what are the shared phenotypes with what we have in our patient, which is noted above, and what are the differentiating features. And here the presence of normal cognition, but like SMA, but they will not have a hypertrophic cardiomyopathy. And that really brings us to this glycogen storage disorder or a mitochondrial disorder, but we would have other things that are also involved in the mitochondrial, including an involved just cognition. A second scenario where we have a 22 years old girl, a 22-year-old girl born to non-consanguineous parents who's symptomatic for the last 12 years with difficulty in climbing stairs. There's a change in gait, there was fatigue and breathlessness, and this has been gradually progressive. There has been no upper limb involvement, no pains, no myalgias, no family history, no bowel and bladder involvement. And so this is essentially the waddling gait. Examination did not show any facial weakness. There was no calf hypertrophy, no scapular winging. And the Gower sign was positive because of the presence of weakness of the pelvic girdle. The jerks were elicited, all other organ systems were normal. Then going into the investigations for this neuromuscular phenotype, the CK, as you can see, was in the thousands. There was a myopathic pattern. There were no myotonic discharges, so it's not a myotonic dystrophy. The ECG and the echo were normal. A muscle biopsy had been done. And it was actually only after this that the diagnosis of Pompe disease was entertained because of the presence of glycogen in the muscle fibers. And after that, an enzyme analysis was done for Pompe for the acid alpha glucosidase enzyme using the inhibitor A carbose, which is very, very important. And you can see here that the level of the total as well as the ratio was low, followed by confirmation of the diagnosis by molecular studies. And so here we had a diagnostic odyssey of 7 to 10 years, which was only confirmed by invasive testing, where actually we should not be doing the muscle biopsy and going directly towards enzyme testing, because we need to think about this. And as I showed you for the first case here, again, we would have a load of differential diagnosis for LOPD because it's a limb girdle phenotype. So the other limb girdle muscular dystrophies, the Becker muscular dystrophy, the type 2 and the type 3 spinal muscular atrophy, not type 2, sorry, type 3 and type 4 spinal muscular atrophy, polymyositis, and you can see the host of other differentials. And then again, as we did for the last case, what are the shared phenotypic features and what is going to separate us? And if it cannot, can I just do a simple blood test rather than a muscle biopsy to check for the enzyme, which would be low only in patients of Pompe disease? So introducing Pompe disease, it's also referred to as acid maltase deficiency, glycogen storage disorder type 2. It's actually named by the Dutch pathologist who first recognized what was happening in the biopsy of these patients. It's an autosomal recessive disorder that occurs because of partial or complete deficiency of the enzyme acid alpha glucosidase, which is a lysosomal enzyme, and very important for degradation of glycogen to glucose. And because this enzyme is not acting in the lysosomes, there is an accumulation of glycogen in the various tissues. And you can see here that these are the myofibrils, they have the normal glycogen. But in patients of Pompe disease, because the glycogen is accumulating inside the lysosomes, they kind of like go and disrupt and push the muscle fibers. And as a result of that, there is impairment of muscle function because these muscle fibers are damaged. And so this is predominantly, we thought, a neuromuscular phenotype. However, there are multiple organ systems that are involved, and I will be coming to that. But what's important to understand is that even before the presentation of clinical symptoms and signs, the accumulation has started in the muscle fibers. And this has been well illustrated in newborns also, who are not symptomatic at birth from Taiwan, who's done a lot of work on newborn screening for Pompe disease. And here we can see that as the symptoms enhance, of course, the muscles have all gone. So if you're going to start finding and treating patients at this stage, we cannot recover the damaged muscle. It is the early phase that has to be identified, and therefore these long diagnostic odysseys have to be cut short to give advantage to our patients. So, as now we know, for most genetic disorders, there is a spectrum. They are not watertight compartments, but the early presentation with the severe deficiency of the enzyme is the infantile onset Pompe disease, whilst as the amount of enzyme is more because of the nature of the variant that is present in the CAR gene, the manifestations are later, and it is referred to as late onset Pompe disease. So there is a very, very definite definition for IOPD and LOPD. IOPD presents in the first year of life with cardiomyopathy, and we can have two types of IOPD, classic and non-classic, whereas LOPD can present anytime, right from the first year to as late as the sixth decade. And it is predominantly a proximal limb girdle muscle weakness and respiratory insufficiency. And if it presents in the first year of life, it should not have cardiac involvement. So that is one of the key things, that a phenotype without cardiomyopathy in the first year of life would be LOPD and not IOPD. Now, classic IOPD presents as early as the first few days of life with cardiomegaly because this starts intrauterine. And hypertrophic cardiomyopathy, there's associated generalized hypotonia, feeding difficulties, failure to thrive, respiratory distress. And it is it has an indolent course. It's rapidly progressive. By 4 months, these children have huge hearts and are very weak with failure to thrive. So most of these patients fail to achieve their milestones. They become ventilator dependent and they die early by 6 to 9 months of age. Whilst the non-classic IOPD has less severe deficiency of the enzyme compared to the classic IOPD, and therefore their cardiac involvement is less. There is absence of the left ventricular outflow tract, which is actually fairly defining in IOPD. And their phenotype is milder and they have better outcomes. So this is a typical IOPD. Now, this child came to attention very early just because he was being screened at the time of immunization and a cardiac murmur was identified. So you can see that he's not as floppy as the first child I showed you, but you can barely have adequate lower limb movements. But yet there are some anti-gravity movements. And the breathing profile, you can see the breathing profile. Okay. And then, of course, you do the CK, you do the AST, ALT, they are elevated. And again, confirmation of the diagnosis, not by muscle biopsy, but by doing the enzyme analysis and the GAR mutation. It's very important that the enzyme analysis, especially we do it in the dried blood spot, because there are non-lysosomal glucosidase enzymes. And therefore, you have to have the inhibitor for those enzymes to get the actual acid alpha glucosidase level. Otherwise, you can get a falsely negative report. So this is the key features: the large heart, even on auscultation, as well as on X-ray, and the ECG changes of the short PR interval and the large QRS complexes. And this is how it progresses. For children without treatment, they become dependent for feeds, they are dependent for breathing, and you can see there's absolute loss of limb movements. This is the natural history that I spoke about, that they have a rapidly progressive course, and we lose a large number of these patients by about 9 to 12 months. Now, this is the global data. Whilst this is the data from India, there was a very nice paper that was put together by Dr. Neerja Gupta. And again, you can see here that there is a rapid fall by about 10 to 20 months of age. Whilst those who have the or the non-classic infantile Pompe disease fare a little. Now, this is how the non-classic IOPD looks like. So while he has cardiomyopathy, he's walking, which is something that most severe classic children do not do. And they have a slightly longer survival than the classic IOPDs. And so this is again from the paper by Dr. Gupta in Journal of Pediatrics, where she has compared in all the patients of IOPD, there were, I think, if I remember now, about 50 patients. The classic manifestations, their developmental delay, can they feed, and the phenotypes of the non-classic ones were milder. 60% of them were walking compared to the classic IOPD children. And so we have a diagnostic algorithm that when you have a clinical suspicion, you would do a CK, AST, ALT, chest X-ray, EKG, echo, but you would not do, this has moved, but you should not be doing a muscle biopsy, but going directly for the enzyme testing in the dried blood spot because it's stable, it can be transported. And once that is low, confirm it by the molecular testing. And sometimes where we have variants which we cannot confirm, or you have borderline enzyme tests, you may do the biomarker. But very important to do the biomarker once the child is on treatment, and Dr. Shankar will be talking about that. And it's important to know the lab where you sent it because these are very, very specific tests. And in the last 10-15 minutes of my talk, I would go on to late onset Pompe disease, where you have the symptoms that are present after the first year of age, irrespective of the cardiac involvement, or children less than 1 year without cardiomyopathy. So it's the cardiac involvement that really defines IOPD compared to LOP in the first year of life. And so the common presentations are the limb girdle phenotypes. And so they will have difficulties in performing, in standing up from the squatting position, climbing stairs, walking, running. But what is something which should give you a clinical clue at the bedside is rising from the lying down position. Because in these patients, the muscles of the trunk are excessively weak. Then there is also exercise intolerance, myalgias. They will have the Gower maneuver, the Trendelenburg sign. With progression, you would have upper limb involvement. The respiratory insufficiency is one of the key features of these, and we've had patients who've presented on the ventilator without being diagnosed, even though they had some form of muscle weakness. And it is this which really is responsible for the mortality. Okay, so this is a child I wanted to show you. You can see his muscle weakness is not significant. Okay, he's got some amount of pelvic girdle weakness. But 48 hours after coming to the hospital, he developed a respiratory infection. And his respiratory muscles were so weak, we were not able to bring him out of that. And so, therefore, It is the muscle weakness along with the respiratory which really defines the phenotype of patients with Pompe disease. And this is the progression of untreated late onset Pompe disease. Very, very severe limb girdle and truncal weakness, which necessitates assistive devices. And so 80% of patients will have pelvic girdle and proximal lower limb weakness, involvement of the respiratory muscles and the trunk and the paraspinal, while you can have muscle involvement in so many other parts of the body with scapular winging, ptosis, etc. And this is how it's defined. They have done. So this is very interesting. When you examine a patient, you see the red, the adductors are involved, the trunk muscles are involved. But when an MRI is done, there is excessive involvement of the shoulder girdle, the muscles of the trunk, the adductors, and the lingual muscles, as well as you can see these muscles here. So it is the axial muscle group and the tongue which is more extensively involved. And another bedside test would be to test the extensors of the neck rather than all these peripheral muscles. So these are really bedside clues to diagnose Pompe disease. The second phenotype, which is very, very prominent in these patients, is respiratory muscle involvement. And they go on to develop chronic respiratory insufficiency, requiring either resulting in acute respiratory failure if it's not managed, or requiring supportive ventilatory devices. So we know that it's a multi-system involvement. But in addition to the typical proximal limb girdle weakness and the respiratory phenotypes, there's a host of multi-system phenotypes that are now developing as for all lysosomal storage disorders. They can present with dysarthria, dysphagia because of the lingual weakness, rigid spine and scoliosis, sleep apnea and sleep disordered breathing. Neuropathy has been reported, hearing loss, as well as aneurysms, cerebral and intracranial aneurysms, cardiac we've already talked about, and GI manifestations with impairment of mobility. So this was some work that we had done and published in Neuromuscular Disorders Journal on the phenotype of late onset Pompe disease. This was a multi-center study with a lot of colleagues from 7 centers. And the diagnosis of LOPD was as the standard diagnosis. And this is just to show the spectrum of manifestations, as we've already talked about in the previous slide, with 90% of them having limb girdle weakness. Cardiomyopathy and rhythm disorders are an important features, but they would not be present early in the first year of life, and that's important to appreciate. I also told you that respiratory involvement is very important. How do we assess for that? The most important feature here is that when you're doing a pulmonary function test, it has to be in the supine as well as in the sitting position. If there is a difference of more than 10%, it suggests diaphragmatic weakness. And in our cohort, we had 45% of patients who had respiratory symptoms. 35 of them required respiratory support. One of them died in respiratory failure. 3 of them could be weaned off to a BiPAP, and 1 continued on invasive ventilation. And this is consistent with the data that is reported all over the world. And so in this graph, then you wonder, is there any correlation with loss of mobility and the need for respiratory support? But in our patients, we showed that there was no correlation. There were many patients who required assistive mobility devices or wheelchairs, whilst they had no respiratory complaints. And there were others who had significant respiratory involvement without requiring assistive devices. And I did show you the image of the first boy who was walking well, but died soon afterwards because of a respiratory illness and poor respiratory result. And so therefore it becomes imperative that we test not only the neuromuscular assessment of the patient, but also the respiratory function. So also to show that cardiac involvement is a feature. These were 8 of the 20 patients who had significant cardiac involvement. And we now understand why is this so more prevalent in our population? Because of the presence of severe mutation. There is a Caucasian mild mutation, which is a leaky mutation present in the promoter region, which is not seen in India. And these severe mutations therefore foretell a severer phenotype of LOPD. Now, these are the spectrum of mutations that are present. This slide I brought in to just emphasize that this is how a patient has to be worked up. It is not just doing exome sequencing to identify the mutation, but it is doing the appropriate enzyme activity, understanding what the level of that activity is, and then the mutation testing. I'm not going to discuss more on this because Dr. Ashwin will be taking the next talk on the mutations and the diagnosis. But suffice to say that the mutations are distributed across all the exons of the gene. And this is the common Caucasian leaky mutation, which is absent in our population. What is the cause of untreated disease? It's progressive. There are a lot of deformities. They develop contractures, scoliosis, osteopenia, porosis, ventilatory dependence, and wheelchair dependent. And I've already told you that there's no correlation between the respiratory and motor function. Now, in that cohort of 20 patients, we also followed up to understand what is the morbidity and mortality of the patients at 3 different points, at less than 5 years, and then 10 years. And we found that it was this cohort who was very severe, that 3 of the 5, where they had a less than 5 years follow-up, they died. There were patients on respiratory and wheelchair support, whilst the ones who survived longer were those who received enzyme replacement therapy, and therefore the mortality was late. Now, in addition to that phenotype, this is also a paper from NIMHANS, which talks about 5 patients who have anterior horn cell disease with hyperactive tendon reflexes, rigid spine, ocular abnormalities. Remember, I told you ptosis is a feature, peripheral neuropathy, and early respiratory failure. So across all phenotypes, across all organ systems of the body, it's just important to have, a suspicion for early testing. So what are the key elements that should alert clinicians to perform a dried blood spot testing for late onset Pompe? It is presence of hypotonia with generalized muscle weakness in an infant or in a 2-3-year-old child, elevated CK, respiratory distress. Look at the breathing by the bedside. Weak diaphragmatic muscles, and the predominant breathing is that of the respiratory, the rib cage. Cardiomegaly, short PR interval board, QRS complexes. It's all by the bedside, nothing, which is hi-fi. Unclassified limb girdle muscular dystrophy, unclassified muscle disease with a restrictive respiratory insufficiency. Ask the patient, do you become breathless while you're climbing stairs? A young adult should not become breathless. In most of the LGMDs, they are not breathless when they are climbing stairs. And disproportionate axial and respiratory muscle involvement in comparison with a limb girdle involvement. And so this is where you must send off the dried blood spot for enzyme testing for Pompe disease. Sorry, that's not late onset. It should be infantile as well as onset. And so with this slide, I conclude. I would like to acknowledge, of course, my department at Sir Ganga Ram Hospital, our lab who has, for the last 20 years, been doing this enzyme testing for everyone in the country. The Indian Medical Advisory Board. Actually, that's where we learned everything, at least I learned everything about Pompe disease and other lysosomal storage disorders, with patients on follow-up for more than about 20 years now. And Dr. P.R. Kishnani, who's done a lot of hand-holding for all our patients with Pompe disease in India. Thank you so much. And we can take questions now or later.
Hello, thank you so much, ma'am, for such a detailed talk. And we'll be taking all the questions at the end of the session, ma'am, just to keep in the timings. So thank you so
Sure.
much. If the audience has any questions, would request them to put in the chat box so that we can actually go ahead and take the questions at the end of the session. Right now, it is my privilege to actually introduce Dr. Ashwin Dalal sir to render the next talk. So I just again, as an official sort of courtesy, I will be sharing sir's CV. So, but again, we all know sir, and it is a huge privilege for us to have sir speak on the diagnostic, like Odyssey, and the diagnostic challenge. Uh, uh, So Ashwin Dalal sir is the head diagnostic division Center for DNA Fingerprinting and Diagnostics Hyderabad. He has over 178 publications and his special interest involves the exome genome sequencing for recessive disorders, chromosome breakpoint characterization, genetic analysis and lysosomal storage disorders. Again, sir has been one of the persons who has been sharing his knowledge very openly, and we are grateful to actually be in touch. And sir, the seminar, the webinar is all yours. If you can please go ahead with your talk. Thank you, sir.
Uh, Thank you, Deepanjana. And so, since Dr. Ratna has given a detailed overview of Pompe's disease, I'll just be dealing with some of the diagnostic challenges that we face and what's the importance of suspecting Pompe disease, because every pediatrician or every clinician may not be able to diagnose, treat, but it's very important that every clinician is able to suspect and refer these patients for testing or refer to higher centers. And we'll discuss some of the challenges that we face at a very basic level of why Pompe diagnosis is sometimes difficult and delayed. So these challenges come up at three different levels. It is either at the level of clinical diagnosis or suspecting a child with Pompe disease. Then there are challenges in doing the enzyme assay and interpreting the enzyme assays. And thirdly, now we have the molecular analysis, wherein again newer challenges come up with the availability of newer broad spectrum assays. So the clinical diagnosis challenges basically come up because of the clinical overlap with many other phenotypes. And so Pompe disease may not be the first thing that comes to a mind of a pediatrician or a clinician who sees the patient. So the infantile Pompe disease, the early presentation is very similar to other infantile diseases which present in a similar way. And similarly, the late onset Pompe also presents as a slowly progressive limb girdle and axial weakness, which again is similar to manifestation of many other disorders which come as late onset neuro progressive disorders. So that is why it is very important to keep this disease in mind, especially because some sort of a therapy is available, some sort of intervention is available for this condition now, and that too free of cost because of its inclusion in the National Rare Disease Policy. The second reason why, again, the diagnosis, the clinical diagnosis gets delayed is because of the variable phenotype that presents in the early onset or the late onset, because of which, since multiple different organs are involved to different degree of severity, these patients may present to many different medical specialties like cardiology, neurology, pulmonology, or to geneticist. And hence, it is very important that that whatever specialty you practice or whichever clinic the patients may present. And this is true with many other genetic disorders also, that unless there is a high degree of suspicion, we many times don't end up suspecting, and hence the diagnostic odyssey of the patient increases to few years. So this phenotypic variability, if we look at the differential diagnosis or the similar presentations, the infantile Pompe can have similar presentation with hypotonia, hypertrophic cardiomyopathy, and respiratory insufficiency, which might be seen, this kind of hypotonia might be seen in SMA or congenital muscular dystrophies or myocarditis or some mitochondrial disorders. And then mainly the cardiomegaly and the high CPK may be helpful, but again, unless you suspect and then plan for a genetic testing or a biochemical assay, these patients may remain undiagnosed. Similarly, the late onset Pompe, where you have a very slowly progressive weakness of the axial muscles with scapular wingding. So these may end up in respiratory failure if not diagnosed early. And many times these get labeled either as limb girdle muscular dystrophies or myopathies or some other degenerative spine disease. So in addition to thinking these diseases, it's important that we keep this treatable disease in mind so that it is not missed. So there should be some red flags that should trigger testing for Pompe disease, either biochemical diagnosis or genetic diagnosis. So a combination of hypotonia, cardiomyopathy, and feeding difficulty. Cardiomyopathy, usually you will not get in SMA or the congenital muscular dystrophies. So a cardiomegaly or a cardiac involvement should prompt looking for Pompe. Similarly, increased CPK or liver enzymes or abnormal ECG. These are some of the indications that can tell us to think of Pompe. And then in the adult onset cases, any patient with proximal slowly progressive weakness with increased CPK, it is very important to keep Pompe in mind to be able to diagnose this. The second level of problem comes in the enzyme assay that is used for diagnosis of Pompe. Now, many times you may either do an enzyme assay or do a genetic testing depending on what's the availability. Enzyme assay helps mainly in diagnosis of a particular lysosomal storage disease or in prenatal diagnosis. So this basically we do it from either the blood, plasma, or fibroblasts. It depends on the lab how they have basically standardized it. And specific artificial substrates are used for this for specific enzyme, like for Pompe disease, it will be the alpha glucosidase that we are measuring. And it is measured in terms of fluorescence or absorbance, two different techniques, depending on which type of LSD that we are looking at the enzyme assay. But most of the fluorogenic substrate, the basic principle is that there is a fluorogenic substrate with a fluorescent molecule attached, and when the enzyme inside the cells acts on this particular substrate, it leads to a product and release of fluorescence. And this fluorescence is measured in terms of certain units, which usually have like the nanomoles, that is the amount of fluorescence emitted per milligram of protein. So that is important to know that every sample may not have the same amount of protein. So it is measured as per milligram of protein, and then how much time you have given for that enzyme to act. So here it is nanomole per milligram protein per hour. So that would be the expression of the units for enzyme activity. So very important to remember that in Pompe or any other LSD, what you are measuring is enzyme activity and not enzyme levels. And so these activities are measured in the cell extracts, and we always compare it with a reference sample. And patients who have usually low enzyme activity, typically less than 10% of normal range, they are considered to be affected. Now, this may again change because in Pompe we have two types of involvement, and so a milder involvement may show a higher enzyme assay. So the sample requirements are basically either from blood. In Pompe disease, blood has a problem because of another similar enzyme that is there in the leukocytes. But fibroblasts are a very good sample for Pompe, but again, they are difficult to obtain because you need a skin biopsy. For prenatal, you can do it in chorionic villi or amniotic fluid. However, most important thing to remember is that if you're doing enzyme assay in a blood sample, always good to send the sample with cold packs so that it reaches the laboratory quickly, or it is done on a dried blood spot where you have to ensure that the spot is dried before sending it to the laboratory. How to interpret the enzyme assay? This is very important if you order for an enzyme assay to know how to interpret it. So first to remember is that we are measuring enzyme activity and not level, and you should have the range written, the range of normal enzyme activity, the units used by that particular laboratory, because you cannot compare result of one laboratory with another unless you look at the unit, and what percentage of mean this activity is shown. And always, whenever enzyme is done, you should always have a reference or a control enzyme activity, as well as another enzyme has to be tested in the same sample to look for any protein degradation. So typically in infantile onset Pompe, you get very less amount of enzyme, less than 1% activity. Whereas in the late onset, you may get a little higher activity. But again, this is not a very specific correlation, and you may get overlapping values. So typically, this is how a typical report of enzyme assay should look like, where it is important that you can see here alpha glucosidase is the enzyme for Pompe disease, and it is expressed as nanomole per hour per milligram. So the patient has a value of 2.1, as opposed to that in control the value is 12. So this is a low value, and then this is the normal range. So these are the three numbers that you need to have for this particular enzyme. And now, as I said, we always do another enzyme in presence of this enzyme assay, which should show normal values, like here the beta glucosidase, which is enzyme for Gaucher disease. And you can see that these enzyme levels are normal in the patient as opposed to a low activity of Pompe disease enzyme. And so the interpretation is that since this enzyme activity is low, and enzyme activity for another enzyme is normal, hence we can say that this patient is likely to be affected with Pompe disease. So it's very important to know how to interpret this enzyme assay results depending on which lab you are sending it for. Now, enzyme assays have their own pitfalls. They are labor-intensive procedures. We have very few labs where enzyme assays is done. And as I said, in Pompe, it is preferred to have a fibroblast, but that becomes difficult sometimes. So there can be loss of enzyme activity because of transport of samples if it does not reach the lab within stipulated time. And there is large degree of overlap of enzyme assay between carriers and normal individuals. So we cannot use enzyme assay for carrier testing. And so these all variable kind of results can hinder the correct interpretation of the enzyme assay. So you should be careful and look for all the values to make the final interpretation. As opposed to this, molecular analysis is always easier. It can be used for diagnosis and prenatal diagnosis as well as for carrier detection, wherein the molecular analysis can either be done by sequencing all the exons and the exon-intron boundaries. But nowadays, because the number of exons are large in many of these genes, so even for Pompe disease, many times we end up doing a exome sequencing, which may detect most of the uh, point mutations. However, you may miss some of the full exon deletions, but the point mutations mostly and the splice site regions do get picked up. So, molecular analysis is very useful for diagnosis when you are not sure of the diagnosis, as well as for accurate prenatal diagnosis, very small amount of sample is needed for molecular analysis in prenatal diagnosis as opposed to a large amount of sample needed for enzyme assay. And carrier detection is best done by molecular analysis only. So many times we end up doing a molecular analysis first, since the availability of enzyme assay might be difficult in many of the regions. But that also poses a lot of challenges. The first of all is if you identify a variant of uncertain significance in Pompe disease gene, then again it becomes relevant that we need to reclassify this. But the reclassification here is much easier because you have a direct functional assay available. So if you have not done the enzyme assay before, and if you have done the molecular analysis and that shows a variant of uncertain significance, then we can immediately plan for an enzyme assay. And a deficient enzyme assay should help us to reclassify this variant as likely pathogenic. So this is important to keep in mind that if you end up getting a variant of uncertain significance in Pompe disease or any of the LSTs, immediate enzyme assay can help to clear out the classification. Secondly, again, genotype does not always predict the age of onset and severity very clearly. So this is also important to keep in mind that based on genotype, we really cannot predict what will be the phenotype, and we'll have to wait and watch because the phenotype is based on multiple other modifier genes which decide how severe the disease will be. And this poses especially a bigger challenge in newborn screening or pre-symptomatic testing in the siblings, where if you identify a mutation, the timing of treatment remains a question because we don't know how the phenotype is going to be in the patient based on the genotype. So these challenges do remain even after molecular analysis that we may do in these patients. So the clinical challenges, the biochemical assay challenges, and the molecular challenges makes it a little difficult, but very important to note is that unless you suspect clinically and then do a molecular followed by biochemical confirmation, especially when you find a VOUS, then you will be able to detect most of the cases of Pompe disease much early so that they can go for early therapies. Uh, However, these challenges need to be tackled at individual levels. If you find a pathogenic, likely pathogenic variant, then usually there is no need of doing a enzyme assay to confirm if the variant has already been reported clearly in multiple patients with Pompe disease phenotype. Next question comes is about the counseling. So what are the goals of counseling in Pompe disease? So typically, like any other disease, we basically are trying to explain the disorder to the family. Why is this disease caused? What's the reason behind it? What is the gene involved? And how it is inherited from the parents? What's the recurrence risk? What's the carrier risk in the next pregnancy or in the relatives? And can anything be done to prevent birth of another child? And then it comes to the supporting the family regarding guidance about the various testings, the diagnostic testing, the cascade testing in other family members, the prenatal options, and psychosocial adaptation for their future therapy or the supportive therapy. So here typically Pompe disease, we have autosomal recessive inheritance pattern. So affected individuals have a 25% risk, which is very easy to understand in a recessive inheritance. And prenatal diagnosis is easily doable with today's era of molecular analysis and biochemical analysis. Many times if there is a doubt regarding the pathogenic prediction of a particular variant, then it is also useful if we do both molecular as well as the enzyme assay in the prenatal sample, which gives us the additional information about interpretation of the variant. So different people in the family will need counseling. For the affected child, the counseling will basically revolve around explaining the diagnosis to the family, as well as the availability of treatment, the outcome of the treatment, the type of treatment needed. They need to really know it's just not that one shot is going to cure the child. Every 15 days, they need to come to the center to take the enzyme. And so the availability of therapy as well as the mode of administration of this therapy needs to be explained. Similarly, the parents need to be explained about the recurrence risk, the reproductive choices, the prenatal diagnosis, as well as implications for the carrier status in the siblings, in the other family members who might be planning for a child in the near future. So, the various diagnostic challenges and the counseling to be offered to these families with Pompe disease. The key message is mainly that and unless we diagnose these patients early by a clear suspicion, many of them will undergo a long diagnostic odyssey. And so it is our very important duty as clinicians to at least suspect and refer these children to higher centers so that they obtain a diagnosis much early in life and are able to take the therapy also. So, that was in brief about the diagnostic challenges that many of us face in Pompe disease. Thank you.
Thank you so much, sir, for such a wonderful rendition of the topic and also exploring the, the challenges with diagnosis. And I'm very sure we have a lot of questions, and I would request everyone to put the questions in the box so that we can take it up later. Thank you so much, sir, for agreeing to give the talk at such a short notice.